commitment to advancing the science of migration medicine, and we are pleased to have 3 distinguished speakers to address issues related to care for the displaced during this pandemic. COVID-19 has tested healthcare systems worldwide, and it's a sobering reflection of our core values, our humanity, and our global connectedness. It brings out in stark relief that despite centuries of gains in health, the most marginalized, including the world's 70 million refugees and internally displaced populations, remain at very high risk during a pandemic for multiple complex reasons. 25 million refugees live not only in refugee camps, 60% of those live in crowded urban areas, and 4.5 million asylees worldwide remain in limbo. Here today to address challenges and opportunities to care for the displaced during a pandemic, we have 3 distinguished speakers. Each speaker is going to present for approximately 20 minutes. Please send your questions via the Q&A on this webinar, and we will address as many as we can at the end of the webinar. And the webinar is also going to be posted as a link on the resource page of both of our societies. In addition, we're pleased to announce that the International Society of Travel Medicine is having a second webinar May 6th on these same issues. So without further ado, I am pleased to introduce our first speaker, Dr. Marty Cetron. Dr. Cetron is the Director for the Division of Global Migration and Quarantine at the CDC. He holds faculty appointments in the Division of Infectious Disease at Emory University School of Medicine and the Department of Epidemiology at Rollins School of Public Health. Dr. Cetron's primary research interests are global health and migration, with a focus on emerging infections, tropical disease, and vaccine-preventable disease in globally mobile populations. For over 20 years, he has conducted epidemiologic research globally, developed global health policy, and led domestic and international outbreak investigations, including high-profile international emergency responses to emerging infectious diseases worldwide. In 2016, he was named a fellow with both the Infectious Disease Society of America and the American Society of Tropical Medicine and Hygiene. Dr. Cetron.
Thank you, Pat. It's an honor to share this webinar with some distinguished colleagues and friends with whom I've worked over many years, and thank you for inviting me. My role in the next 15 or 20 minutes is to try to give you sort of a high-level overview of context from what I call the holy trinity of infectious disease, and help set this stage for the other speakers as to why these specific issues are so poignantly challenging in displaced populations of all sorts, migrants, refugees, forcibly displaced, and otherwise. So the Holy Trinity is the virus, the host, and the milieu. Let me start with the virus, reminding folks it's only been on the planet for, in humans for maybe 4 to 6 months. We don't exactly know the first case, but not a very long time. And the first thing to remember is I have learned over 3 decades at CDC that humility is probably the #1 issue in dealing with a newly emerged virus. Sometimes what we think we know based on our past experience is not going to play out, and Mother Nature is a pretty powerful innovator in terms of surprising us. So what have we learned about this that we really didn't know at the very beginning, and why does it matter with regard to this, this population? #1, this is an extremely stealth virus capable of a lot of insidious spread. What I mean by that is we've learned pretty clearly from a number of closed space outbreaks and investigations, whether they be cruise ships, detention centers, camp settings, migrant camp settings, or in fact, the populations in workplaces, crowded, densely populated workplaces, that when full testing has gone on, between 25 and 50% of the infections can be either pre-symptomatic, that is people testing positive before they develop symptoms, or asymptomatic, people testing positive without ever developing any symptoms whatsoever. This is a pretty challenging aspect of this virus, and some recently in the New England Journal have called it the Achilles heel of control. And in fact, it makes it super difficult to know where this virus is without a robust, comprehensive testing capability, which has been challenging worldwide. The other thing about this insidious virus is, unlike some viruses in which the viral load increases over the course of infection and is highest at the time people are most symptomatic, for example, Ebola, in this setting, the virus has extremely high viral loads beginning at least 48 hours prior to symptom onset, and in some cases, it's even more than 2 days, which means that people are most contagious at a time where they're least likely to recognize something wrong, and therefore they can contribute to a large amount of the spread of this epidemic before any. Another characteristic of the virus is its fast math. By this, I mean the reproductive rate estimates, and these vary across settings, obviously, but the reproductive rate are not. The number of people infected from a single person in a fully susceptible population has varied from lows in the high 2s to 3 to some settings where it's reported as high as 6. This means that the virus is going to grow at exponential rates. Doubling times for numbers of cases are measured in days, not weeks. And this is especially apparent during the rapid acceleration phase. So after there's a little bit of seeding, it is not very long before the virus can take off in its fast math manner. The third key thing is recognizing that this virus, although we're still fully uncertain of its case fatality rate, appears to be extremely virulent. And part of our uncertainty stems from not knowing how many people are actually infected in the denominator, nor how many deaths that will have occurred worldwide by the end of the first wave. But the estimates of its virulence in terms of fatality and morbidity, I've seen anywhere estimates of 0.5 to 1.5%, making it either 5 times or 15 more times more severe than influenza. The high morbidity has also been a challenge of this virus, and that although there's disproportionate risk in the elderly, it is occurring, the infections and severe disease are occurring across all age groups and in sometimes very unexpected ways. The toxicity of this virus, while initially looked at as a respiratory virus, we are now learning has the capability to target many more organs, in particular beyond the lungs, the heart, the kidneys, the neurologic system as well, resulting in strokes, in multi-organ failure, in also a kidney failure requiring dialysis. So it's a virus that has, as other coronaviruses, the potential to mutate and the ability to target multiple tissues, although it's primarily a respiratory virus. The transmission is mostly by large droplets, which go behind the recommendations on maintaining 6 feet of social distancing. But in fact, we've seen in some environments heavy contamination of surfaces, like on cruise ships, and the ability to generate aerosols in closed spaces, perhaps emergency rooms or other kinds of settings, can allow for limited airborne spread as well. So the virus is quite challenging, probably the most challenging one that I've seen in 3 decades, and certainly giving us the greatest challenges since the 1918 pandemic. What about the hosts? Well, the hosts here, there are a number of factors which associate with severe disease. Age was the first one to come out, but as I said, we're seeing the full spectrum of hospitalizations, ICU admission, ventilator needs, and death across the entire age spectrum. The underlying conditions of hypertension, diabetes, chronic renal disease, cardiac disease, other pulmonary disease, obesity are notable in the disproportionate impact on severe outcome. What we don't know fully yet is the role of other things like HIV co-infection, malnutrition, and other co-infections and respiratory viruses that are so common in the vulnerable populations of these migrants that we're speaking about. And third, to wrap up, is the milieu. So the virus, the host, and finally the milieu, or the environment in which this virus is spreading. This perhaps to me is the most important thing that is often neglected when we try to combat epidemics. The milieu can take what is a familiar virus and make it actually very lethal and very challenging to control. This virus, because of its existential threat, has led to a tremendous amount of fear, perhaps appropriate in many ways, but also the stigmatization of populations, and with the stigma, the attempt to turn victims of the disease into vectors of the disease. And I think this is a special risk that we see with regard to displaced and vulnerable populations, especially in a multinational setting. The other aspect of the milieu is its control has resulted in probably the most extreme approach to nationalism in disease control that we've seen also in a century, with a routine closing of borders, restrictions of populations, a tremendous amount of inward focus and protectionism. And this obviously has special challenges for the populations of concern to us. But there are additional factors as well. Most of the recommendations for mitigation of this virus involve social distancing and reducing density and crowding. These are really difficult and challenging with regard to the vulnerable populations. Poverty is also clearly, the virus is exploiting poverty in obvious ways, not only in the ability to compete for resources and have access to PPE and healthcare services, but also reflected in the type of work that migrants and refugees and displaced populations are often engaging in. They aren't necessarily a big part of the knowledge work community that can easily social distance in the comfort of large spaces at individualized homes, but in fact are working in very crowded, constrained settings, and often returning to multi-generation and densely packed housing situations, whether they be in camps, whether they be in urban centers or in the resettled populations in our cities, in some of the poorest communities. We've seen in the United States the highest attack rates occurring in these types of communities, immigrant, refugee, migrant communities, where the workplace and the home environment amplify each other and create a source of impact. We also know that these populations have disproportionately impacted by broken healthcare systems in terms of healthcare service delivery. They often have increased underlying health conditions that make them more vulnerable to severe disease. And in fact, they are suffering from the challenges in transportation disruptions in terms of getting access to supply chain, to routine healthcare needs, routine public health needs like vaccination. It's notable that during Ebola, more people died of measles, more 8,000 cases in the DRC than succumbed to Ebola itself. And the uncounted toll of morbidity and mortality really remains to be determined. I guess I'll end with just more sort of one comment regarding the unique setting that we see a lot of the migrant and displaced populations facing. In the United States, we have more than 18 states facing large-scale outbreaks, by the hundreds, if not thousands, in the meatpacking industry, in particular beef, pork, and poultry industry now across several states, with the closure of these plants, placing a significant jeopardy on the food supply. The same is going on with regard to the agriculture industry, which is disproportionately serviced by these disenfranchised populations. And so I will end just to say that this virus at this time in these hosts and in this milieu is representing a very serious threat that needs unique solutions and unique challenges. Thank you for giving me a chance to sort of open up and paint the picture, Pat, and I'll turn it back to you.
Thank you very much, Marty. Fantastic overview. Appreciate it very much. As I mentioned, we'll have people send questions through the Q&A, and we'll take those questions at the end. Our second speaker, it's my pleasure to introduce Eric Schwartz. Mr. Schwartz became president of Refugees International in June of 2017. He has had a 3-year decade focused on humanitarian and human rights issues. Between 2009 and 2011, he served as U.S. Assistant Secretary of State for Population, Refugees, and Migration, during which he was credited with strengthening the State Department's humanitarian advocacy around the world, initiating and implementing critical enhancements to the U.S. Refugee Resettlement Program, and raising the profile of global migration issues in the U.S. foreign policy sectors. He was also the senior human rights and humanitarian official at the National Security Council during the Clinton administration, and managed humanitarian responses to crises in Africa, Asia, the Middle East, and Europe. He served as the UN Deputy Special Envoy for Tsunami Recovery after the 2004 Asian tsunami. And just prior to arriving at Refugees International, he served as the Dean of the Hubert H. Humphrey School of Public Affairs at the University of Minnesota. Eric, thank you for joining us.
Thank you, and what a real pleasure and honor to be with such distinguished panelists. As Pat mentioned, I am indeed president of Refugees International, an international refugee reporting and advocacy organization. We focus exclusively on field reporting and advocacy. So while governments, non-governmental organizations, and others are organized in a way to support humanitarian response through service delivery, which is of greatest interest and concern to our organization as well, we ourselves are not providers of food, healthcare, medicine, and other services. So that, combined with the fact that we neither solicit nor accept contributions from governments or the United Nations, enables us to be independent and forthright in our advocacy. And on March 30th, we issued a global report on the COVID-19 pandemic. And our recommendations, and I was going to try to screen share the report, but I don't want to take any chances. So you can find the report at our website, www.refugiesinternational.org. But the recommendations of our report would not surprise anyone at this meeting, and I will go through them. On issues familiar to all of you here, we said, and I quote, that donors and international aid groups should prioritize the deployment of qualified medical personnel to refugee, asylum, and IDP dense areas, along with personal protective equipment and other medical supplies, such as gloves and masks for humanitarian health workers, to ensure their safety in addressing outbreaks in displacement camps. We said that appropriate training for existing healthcare personnel must occur, particularly for the treatment of severe cases with limited ICU access. We said that donors and international aid groups should improve access to water, to sanitation, hygiene facilities for refugees and internally displaced populations, especially those that live in camps or camp-like settings, and that this should include the distribution of essential personal hygiene items. The response should also recognize best practices for response for particularly vulnerable populations, such as women and girls. And we said on these sets of issues, and I quote, that donors, host governments, and international aid groups should prioritize decongestion and building isolation and quarantine capacities in camps and camp-like settings, that services like food delivery, like food distribution and education should be restructured to avoid large gatherings, that donors and others should take steps to support the establishment of capabilities within displaced communities for implementation of isolation and quarantine procedures in accordance with best medical and public health advice and practices. We noted, given the extremely high density of certain settings, the possibility of novel strategies for shielding that might need to be carefully attempted. Finally, we said that donors and international aid groups should prioritize deployment of rapid testing capability in adequate quantity to refugee and IDP settings. And with respect to surveillance, we called for strengthening of epidemiological surveillance systems already in place and their adaptation to screen for COVID-19, especially for new arrivals. I should note parenthetically, although I don't want to blame him for any flaws in our report. We received great advice from one of my co-panelists on these recommendations, Paul Spiegel. So Paul, thank you again. Now, none of these recommendations will be surprising, I think, to most people who are listening or watching this webcast. The question to my mind is whether much of it will ultimately much of these recommendations are feasible in the context of a response, the magnitude of which is at risk of being inadequate. As we have seen in the United States, the COVID-19 pandemic is having a very disproportionate impact on communities that have historically been marginalized. Over the last few days, National Geographic, citing data from CDC and data gathered by the Associated Press, reported that nearly a third of COVID-19 infections in the United States have impacted Black Americans, even though Black Americans characterize about 13% of the US population, and that this same community constitute a similar percentage, about 1/3 of COVID-19 related deaths in the United States. So it's not surprising that those who have been subjected to structural inequities, structural inequality, are suffering disproportionately in the United States. And I would suspect, but don't know for certain, in other countries. And it shouldn't be surprising that among the most vulnerable of the vulnerable, refugees and other displaced persons who also have been subjected to profound inequities and inequality, among these populations, we will be finding far more disproportionate impacts. This reality conflicts starkly with the very principles that humanitarians have long argued should guide humanitarian response, including the principles of humanity and impartiality. Humanity, which embraces the concept that the well-being of all people, wherever they happen to reside, should command the attention of all of us in a position to help. That on a profound level, the well-being of a COVID-19 sufferer in your neighborhood is of no greater or lesser intrinsic importance than the well-being of a young Rohingya refugee in a camp in Bangladesh who is at risk of testing positive for COVID-19. And the principle of impartiality, meaning that assistance should be provided to vulnerable communities and individuals based on need and nothing else. In the current circumstance, the best way perhaps to secure the achievement of these kinds of principles globally, to my mind, inevitably will be resources. In the COVID-19 pandemic, I think that the principles will be meaningless without resources. And to my mind, and this is not a science, let me say that this is not a scientific observation. This is an observation based on 30 years of policy experience. The international response, with an appeal thus far from the United Nations, at least as of several days ago, of about $2 billion has been wholly inadequate. I believe that the response of my own government, the United States government, has likewise been wholly underwhelming. The $800 million or so in the United States COVID-19 emergency legislation that was focused on international humanitarian response represented not 5%, not 2%, not 0.2%, but about 0.02% of some $3 trillion that the Congress has appropriated overall thus far to address the COVID-19 pandemic. If we let our imaginations take over, and if we say, for example, that the American government would by itself fund a tenfold increase in the international response, or at least in the international appeal. That might cost about $20 billion. Even at that level, the international humanitarian response portion of the overall COVID-19 legislation would amount to less than 1%. I wrote those remarks some days ago, but yesterday I saw a quotation from Jeff Sachs, which reflected my own view when he said, in the context of assistance generally, and I quote, "So this is not fundamentally about resource constraints, it's about caring, attention, philosophy of life, and politics, a sense of ethics and morality." And I think we are at risk of missing, with respect to the resource issue, I just feel like we may be at risk of missing the forest for the trees, that this is a critical issue that requires the attention of all those who care about the response to the forcibly displaced who are going to be and who are being impacted by COVID-19. And while I think this may be the most significant issue, there are other factors that my organization, Refugees International, and I have emphasized in our reporting that are also focused on what I would call rights-related factors that impact the overall response. So I think I'm still within my time, so let me just talk briefly about some of those. Here again, permit me to quote liberally from our report when we said that the overall response must be inclusive, that international assistance to address the pandemic must reach all vulnerable populations, including refugees, asylum seekers, and the internally displaced. That governments should ensure that the forcibly displaced living in both camp and non-camp settings are included in prevention and mitigation efforts, and that by the same token, aid for refugees and IDPs to address the pandemic should be made available to host communities in refugee hosting areas. In short, the aim has to be to improve systems for all persons, regardless of nationality. We argue that governments and international aid groups must privilege information sharing and the free flow of information, that in circumstances like this one, rumors abound and can be very destructive to public health objectives. In places like Bangladesh, where we've seen troubling restrictions on access to information among the Rohingya community, governments must lift phone and internet restrictions in and around displaced communities. And we also argued that in order to achieve key objectives, whether that means deployment of medical personnel, supplies, and personal protective equipment, et cetera, governments must permit, to the greatest extent possible, freedom of movement for essential personnel while defining essential personnel in a way that is reasonable. To very limited, if any, effect, we have also urged an end to detentions. I wouldn't say to no effect, but to limited effect. We have urged an end to detentions and deportations of asylum seekers, noting that detention in crowded facilities increases the risk of transmission for those in custody, not only asylum seekers and immigrants, but also, and other immigrants, but also immigration and border officials. Governments should put in place alternatives to detention policies and ensure that migrants have access to testing and healthcare regardless of their status. Deportation, we've taken the position that deportation of any individuals without prior medical testing, especially from the United States, risks exporting the virus into countries unprepared to deal with mass outbreaks because of pre-existing crises and substantial, vulnerable, and marginalized populations with little access to limited healthcare systems. And we have urged that any restrictions that governments impose on travel should include provisions that safeguard individuals from forced return, to torture, to persecution. Moreover, extraordinary policy measures that impose unusual burdens for those seeking asylum should be lifted as soon as circumstances permit. In fact, today, this morning, we issued a report, an issue brief, called Expelling Asylum Seekers is Not the Answer, co-authored by our U.S. senior advocate, Yael Shaker, and Paul's colleague, Chris Spira, head of the Bloomberg Center for Health and Human Rights. In times of national emergency, protecting vulnerable people from gross abuses of their rights can become more challenging for governments. We can offer a range of evidence-based arguments about the absence of public health rationales for discriminatory policies, but fear is a very powerful factor. And politicians can often find, tragically, political benefits in stoking such fears. So there are no simple answers to this challenge, but it is clear that even as protecting people from abuses of their rights becomes more challenging, it is at these very times that our commitment to those rights is decisively measured.
Thank you very much, Eric. That was fantastic. Thanks for your advocacy and work on policy for so many years. Again, a reminder, please send in questions. We have a couple of questions coming in, but please send more questions. It's my pleasure to introduce our third speaker today, Dr. Paul Spiegel. Dr. Spiegel is a physician who's internationally recognized for his research on preventing and responding to complex humanitarian emergencies. Before becoming the Center for Humanitarian Health Director at Johns Hopkins University, Dr. Spiegel was the Deputy Director of the Division of Program Management and Support Services for the United Nations High Commissioner for Refugees. In 2002, he worked as a medical epidemiologist in the International Emergency and Refugee Health Branch at the CDC. He has worked as a medical coordinator for Médecins Sans Frontières and Médecins du Monde in refugee emergencies, as well as an internationally recognized consultant in the field with numerous organizations. So, Dr. Spiegel, thank you for being here, and the floor is yours.
Thank you, Pat. Pleasure as always. And if I can, Doug, if you can, yeah, I think you're trying to bring up. And thank you, Eric and Marty. It's always a pleasure to be in a panel with you. I learned a tremendous amount. So I'm going to, I think it's a nice transition. I'm going to try to explain to you some of the projections that we have been undertaking using the Rohingya refugee camps as an example, what we're finding, and also clearly some of the limitations. And Marty mentioned that there is a lot that we don't know at this point. And then I'm going to talk about another project that I want to share with you, which is trying to better share field adaptations, context-specific field adaptations in humanitarian settings. So next slide, please. Great. So here is the Cox's Bazar. In Cox's Bazar, there are approximately 890,000 refugees, for Rohingya refugees, and we wanted to study, together with UNHCR and others, a part of that, the Kutupalong Balakali expansion site, of which there are not 596,000 people. If you look at the density, it's one of the most dense places on Earth in terms of living, 46,000 people per kilometer squared. The other thing that I think is really important to see, and you probably can't see my mouse, I don't think, but if you look at the age distribution and you compare it to China and look to your left, you will see that in China you have a much younger, an older age distribution, and when you look at the curve that's going all the way down the blue, at least it's blue on mine, you see that there's a tremendous amount of young people, particularly young children in these camps, and this has an interesting effect. Next slide, please. So, and this is not my expertise, I'm an epidemiologist, and I'm working with some wonderful modelers, Andrew Asman and Sean Trulove of Hopkins. And so this is the stochastic model that we have been using Just briefly, you're looking at the susceptible individuals that may contract the virus, the actual disease itself, COVID-19. You're looking at the number of exposed individuals that are incubating the disease after being in contact with someone who's been infected. The I is both looking at the infected and infectious individuals, and then finally looking at the recovered individuals. We wrote here with immunity to reinfection. Unfortunately, that's looking too optimistic at this point. So we have to actually change that to say with, we even don't know that at this point. Next slide, please. So what we did is we developed at this point, and we're already looking at different camps, and we've modified how we're doing this. But early on, we looked at 3 different transmission R naughts, the reproductive rate that Marty was mentioning. So we looked at a low rate, which was influenza-like. We looked at a higher rate, which is, or we called it moderate, that's the blue, and that's what was happening in Wuhan. And then we looked at a higher transmission rate because we are concerned, obviously, about the lack of hygiene, the density of population in these camps. And so we wanted to try these different scenarios. We're currently modeling for UNHCR now, and we've actually taken away the low rate because we know that's not going to be realistic. So we're now using the moderate and the high transmission. And these are just the red, so it's the high transmission, which I think would be likely in these camps. It's what this really shows you is the amount of infections that will come very, very quickly. And this is looking at transmission alone. This is not looking, and for this particular model, we aren't looking at interventions such as social distancing, of which we are trying to introduce now. But the point of doing this modeling, and this came out in a preprint maybe 3 weeks ago now, was to allow the community to, number one, see how infections could move very quickly amongst this community. And go to the next slide, please. And then to allow them to prepare. And so then what we did is we looked at with these low, moderate, and high transmission rates, which are to the left, we looked at the number of infections at 1 month, 3 months, and 12 months. And 12 months is a long way out. And again, this is without doing any interventions whatsoever, and I will discuss some interventions that is occurring now. But if you look at the 3 months, for example, and again, this is 590,000 people. So if you look at 3 months at the high transmission rate, you're going to have nearly everyone's going to be infected after 3 months. The moderate transmission rate, you're going to have 99, let's call it 100,000. And then you see is at the low rate, which we think is less likely. Then what we look at are the numbers of hospitalizations, the intensive care units, of which there are none in that camp, but we put this in just to be able to show this, and then the number of deaths. And so you can see what a difference how the transmission and the reproductive rate that Marty talked about. And as we said, 2 to 3 is moderate, but it's likely, we believe, 3.3 to 5. So you'll have a significant number of deaths. What is interesting, though, and I want to point out, and we'll see this, I don't know if we'll see this in other slides, so I'll mention it now, is that the demographic characteristics are hugely important here. And we are learning, and we will be surprised, we think. But at this point, using the China from US, Europe, and China itself, we're proportionally, the number of deaths in this camp will be much lower. Again, it's proportionally to these other countries because of the very, very high younger population and significantly fewer people over 60. But there's a big caveat, and Marty mentioned this briefly, and that is that we do not know how the virus will react in places that have already a very poor baseline health. We did add here that we have a significant acute malnutrition rate here. HIV here is not a big issue, but in Southern Africa and many other parts of Africa, it is. And so we think this is clearly an underestimation of the deaths, but it's something to look into. And then secondly, the data here in terms of death, the modeling takes into account, because it's being used from these countries that I mentioned, in regions, China, Europe, and the US, that there will be sufficient access to ICU beds. And we know that that will not be the case here, and I'll get to that shortly. Next slide, please. I think this is an ugly slide, but what we wanted just to show you was that the other thing that we're trying to do is to look at compare on, you'll see the Kutupalong site. And so we're looking at, for example, what is the current crude mortality rate and under 5 mortality rates. We're looking at what it is in Bangladesh, and then we're looking at various standards to try to make a comparison of before and after. And you don't need to go through all of this, but what's interesting to see is that despite the horrific conditions in these camps, the international community and the Bangladesh government, and I should switch that, the Bangladesh government, who's been quite good and quite generous in accepting all of these people, they've done a good job. There have been measles outbreaks. There was a diphtheria outbreak. There was a massive oral cholera vaccine early on, so there's not been a cholera outbreak. Overall, they've been doing quite well, but it's extremely fragile. And therefore, we think that with this, when there will be, and we do think it's a matter of time, how this virus will react in this community will be very, very disturbing. The other thing to add is I've checked already. Again, there's definitely been one confirmed case in Cox's Bazar already of a Bangladesh person. To my knowledge, and I checked as of 2 days ago, there have not been any confirmed cases in the camps as of yet. Thank goodness. Next slide. So some of the broad recommendations are, we have been speaking now to many different NGOs and UN agencies in refugee and IDP settings. One of the concerns is that not everyone is making a realistic plan. And what I mean by that is that for refugee settings and even IDPs, you're there at the behest of the government, or you're there and the government is autonomous. And in many situations, as and when the pandemic gets worse, or let's call it the epidemic in that country gets significantly worse, there's a lot of concern of how governments will react to refugees and IDPs. And if there is an overwhelming increase in cases, such as we've seen in Milan and in New York, and the beds are completely occupied by, the beds will be completely occupied and the minimum little amount of ICUs that there are will be occupied. Do we really believe that the national governments will equally offer all of the hospitals and the national hospitals to the refugees and the IDPs, as opposed to, now IDPs, they are nationals, but they're often discriminated against. So what will happen there? And in many situations, we've seen a lot of the plans are not taking that into consideration, both for political reasons and because the governments have not said that they're going to do that. There is only one district within a country, which I will not mention, that has clearly said, already changed the policy and said there will be no tests for refugees and they will not have access to our district hospitals. It is my feeling, and I'd love to hear from others on the panel and who are listening, but it's my feeling is that if there really are many cases in these districts where refugees or IDPs are located, we will quickly see a change of policy. Number two is there will not be, we talk and we learn a lot. We have learned a tremendous amount about Ebola and how the international community responded to Ebola. This is clearly not Ebola. And there will not be a surge of international community. There will not be a surge of money, as Eric has already mentioned. So there will not be a surge of human resources into these camps. And in fact, some camps have already been, the governments have locked them down and there's no more movement. There will not be a surge of nationals and there will not be a surge of internationals for obvious reasons. And therefore, we are going to have to deal with what we have in those situations, and I'll get to some of the task shifting shortly. And then there's a big concern about staff protection. And so many organizations and or the governments have already said people they have significantly reduced access to refugees, in particular refugee camp settings, because when you're integrated, it is slightly different, but we're still concerned about access. So how can some of these programs be adapted? We have, and I'll show you on this new website we've developed, but we have COVID specific, we have COVID sensitive, and then we have cross-cutting. And the COVID specific are issues like social distancing, shielding that was discussed. So how are we going to, with the COVID specific, how are we going to isolate suspected cases in camps such as the Rohingya or in Bidi in Uganda, where you have so many people in a relatively small area? I think it's going to be extremely difficult to be able to do. There's insufficient land. There is a London school, and a couple other of us have talked about this issue of shielding, which is particularly important before there have been any infections. Can you shield off or isolate the most vulnerable? Can you do this for the elderly and the medically compromised? This has to be done at the community level because of the cultural, you can imagine people saying, well, we're not going to move our grandparents away from us. And so it may not be reasonable in many refugee high density settings. It may be reasonable in villages and others where everyone knows each other to move some of the most, shield some of the most vulnerable people and then make sure that they have food, etc. This was discussed in the Rohingya and in the Rohingya setting about shielding and considered doing this amongst families. It was ultimately rejected both because of the concerns that there could be infection already and then the ethical and cultural issues. Another area would be looking at the COVID sensitive. So for example, schools have already been closed in many of these settings. General food distribution and other mass distributions have to be changed. They either need to be decentralized, so you have fewer people, or they need to be done in a much longer period of time where you have fewer people coming to there, but you need to be able to distance them out the same way as what's happening for many of us when we're standing in the queues in front of stores, some grocery stores, when we're waiting to go in. But this needs to be done consistently in all of our programs. We need to look at what is happening and saying, okay, if we're doing nutrition programs or if we're doing SGBV programs, sexual gender-based violence, what are we doing to be able to make sure that we're not inadvertently spreading disease? And then there's going to be will have to be a tremendous amounts of task shifting. There are in Kutupalong, for example, there are doctors. They may not be used to taking care of extremely sick patients. There are some hospitals, no ICU, but they have some oxygen. We may have to train up those doctors to deal with the most severe cases. We may have to train nurses to deal with moderate cases, and then community health workers, or maybe we take the teachers that are no longer teaching and we repurpose them because they're often very well educated to be able to deal with some of the, let's say, cases that can stay at home. But then you've got that additional challenge of how do you keep those people safe and how do you also make sure that they don't spread the disease within the community. Next slide, please. So this is the last recommendation slide, and then I have something else I want to show you briefly. We need to look at inadvertent consequences. We're already seeing in other countries an increase in sexual gender-based violence and intimate partner violence when you have lockdowns like this. There may not be lockdowns, or there may be lockdowns in these settings, but we have to be prepared for that. Marty had mentioned an increase in, there were more malaria deaths in West Africa than there were Ebola. I am confident we're going to see the same thing here as things move on. And that's just, and we saw this in, we believe we saw this in the massive cholera outbreak in Yemen. I just spoke to someone in Myanmar today who's working, and they're already working and trying to figure out in their mobile clinics how they can have two separate triage, those that don't have fever and those that do have fever, and then trying to isolate these. Eventually, those people that do have fever. We need, there's stopping of, as we know, of wide-scale immunizations. So there's going to be a lot of inadvertent effects that are going to happen. We need to look at a lot of the non-camp settings and see how we can work in terms of access in these non-camp settings to most refugees and IDPs in urban settings are accessing national systems. And will they still be allowed to access national systems in the future? We don't know how social distancing will affect the trajectory of the epidemic of the virus in these settings. We don't know the effects of acute malnutrition, HIV, as Marty had mentioned. So we need to be able to put systems in place to be able to follow that and actually see. And I'm afraid right now that those systems are not yet in place. Eric had mentioned already very clearly, and we're seeing this, that public health safety, public health orders cannot be used as an excuse to increase anti-refugee sentiment and what we call refoulement, of pushing people across the borders. We're already seeing this in the United States. We're seeing this in Greece, and we have to be very vigilant. Next slide, please. So I wanted to just present to you, this is a joint website that we just launched last week, and it's in conjunction with the London School of Tropical Medicine and Hygiene and with the University of Geneva and the Graduate Institute of Geneva. It's a group called SARA that works in epidemiology and research in humanitarian. So it's the three universities that are working together. And what happened is my colleagues and I kept on getting a lot of calls from various NGOs and UN agencies and saying, what do we do with our food distribution? What do we do with case management when we don't have ICUs? So we got together quickly and we put up a website, and the whole idea of this website is we have a framework where people can click onto, and then there are the latest guidelines that we are aware of, and we're getting more and more guidance to be able to put on. And then in that white area, share your field experience. And this is probably the most important aspect, is we are asking people to share their context-specific experiences of what are you doing in your settings. Next slide, please. Because we need to be able to have a place where people can go and actually see what to learn from others, what they're doing, because no one is waiting for us. They're already doing, and the more and more people we talk to, the more and more interesting experiences that we're seeing. So this is the actual platform structure. You look into COVID specific, adapting COVID interventions, COVID sensitive, and then some of the cross-cutting issues like protection, gender, logistics, etc. Next slide. Here's the second to last slide. 30 seconds, I see. So this is what the share your field experience looks like, and we'll also be putting this in French. What's key is we have the country, are you urban, rural, are you an LIC or a middle income country, what's your status, refugee, IDP, migrant, camp, non-camp. And then you choose your category of COVID and ultimately your area, and then you can upload. We have to be careful that we don't put up any bad experiences, so we curate all of this. And then finally, what we do is we will be having students doing a lot of interviewing because people are so busy. So we've already undertaken about 20 interviews, putting them into a standardized way, and then we'll be sharing them. Next slide and last slide. Just to acknowledge my colleagues, and then last slide, please. And that's us. So thank you very much. I look forward to hearing questions and comments.
Thank you very much, Dr. Spiegel. That was fabulous. It's nice to see that on the ground work that you're doing, as always. We do have some questions that have come in both on the chat and on the Q&A. Maybe I'll stick with you, Paul, for the first one. It says, question for Dr. Spiegel. At 12 months, there tends to be a similarity in outcomes between the three infectivity profiles. Can you comment on that?
Yeah, that's just purely because the transmission is just slower. You have different levels. So the high transmission will start very quickly, and then the lower transmission will take longer, but we'll all get there at the end. This model that I presented has limitations, as I mentioned, that we did not at that time put in effects of social distancing. And the latest models that we just shared with UNHCR we have decided to put in low social distancing and moderate social distancing, and that also will affect the transmission. But 12 months out is quite long to be able to project. So it was we did it to be consistent, but we are going to be seeing a lot of changes, and if we learn more, the models are going to improve.
Thank you. Yeah, it's been amazing watching all the different models that are available that we can all study, and recognizing that they relate obviously to the input of those models. So in terms of that issue of social distancing, another question came in, which is a good one and a practical one, which is when we talk about isolation in refugee camps, this is not possible. So what's the best way to deal with that issue? I don't know who wants to take that, but how can you possibly, with those photos you showed, Paul, for example, those of us who've worked in camps, how do we possibly isolate?
Yeah, this is going to be one of, I think, the really interesting questions. And that's one of the reasons why this concept of shielding came up, which has caused some consternation. Again, the idea would be, well, we know we're not, two things, I think. Number one is we have to differentiate between social distancing, having enough space between us to reduce infection, versus isolation, which is really you have a suspected case and then you're going to be, hopefully you've done your contact tracing and you're isolating. So it may at the beginning be possible if you have, and they do have enough contact tracing. I mean, they have a lot of community health workers there. So early on, if there was enough testing, of which there currently is nothing close to that, there could be ways early on to isolate people in areas. They have some old diphtheria clinics, and they have schools and others that they could do. So isolation at a small scale may be possible. At a larger scale will be extremely difficult to do. Social distancing will be even more difficult to do. And, you know, could we be working, and I did learn also in many camps now, there are local groups making masks to be able to try to reduce. So maybe everyone is going to be wearing masks and they're going to change their behavior a little bit, and you reduce all of the mass distributions and the mass gatherings. And that may be the best that one can do at this point.
Marty.
I just wanted to add a comment to this. I think Paul's spot on. It's going to depend on where we are in the phase of an outbreak in a camp setting or in an urban setting among these populations. But the individual isolation is a little bit based on either testing or symptoms. Symptoms have been problematic, but it's definitely a place to start in the absence of testing. But I would say the next kinds of things to think about is cohorting. And that kind of cohorting can occur in addition to shielding. So essentially what we've seen across this is we've seen sort of 4 groups of fundamental types of cohorting. A group of sick people with presumptive disease based on case criteria we would sort of label this the red zone, where you try to isolate in a cohort those that are sick and not essentially just having them fully mixed. An exposed group, maybe the yellow zone, where we have a quarantine place, that could also be a cohorted space. There's of course the green zone, and that's the confusing one. It's because people who look well could easily be infected, and the challenge of verifying the green zone is pretty significant. It may be an important staging area for people rotating through, healthcare workers, other service members who have some definitive approach to testing or to cure, and thinking about that in that space. And then there's this shielded zone, which is a subset of the green zone, if you will, that Paul talks about a lot. And I think it's really important to think about how we do shield the most vulnerable for severe outcomes, and how do we service the shielded zone with the appropriate. And in some ways, we think about this in our domestic experience with the challenge of dealing with nursing homes in that setting, for example, as a starting point. But I think we shouldn't forget the basic infection control criteria that we could use for red, yellow, green, and shielded, if you will, subset. And although that, when you look at the pictures, you say, how do we even begin to get there? Some of these basic public health measures are as old as time, as old as human history. And we can try to do our best. It doesn't have to be perfect in order to make a contribution in introducing the R0.
Mm-hmm. Thank you. Here's a question that makes me think about, Eric, your comments about fear. And certainly any of the 3 of you could address this, but it's a question about how can we avert mental health issues in camps like Kakuma in Kenya or elsewhere? As we know, mental health is already an issue even in stable settings. And I think about that, the importance of communication in refugee camp settings. And in the context of that, and the context of fear, maybe lack of access to, any sort of intensive care, the mental health issues are going to be very, very significant. And I don't know if any of you want to tackle that question.
Well, Pat, you largely said what I would have said, but I'll say it anyway. I think I think it underscores the importance of the recommendation that we made regarding the provision of information, of freedom of information and access to information, because as I said, in circumstances where rumors abound and people don't know what's going on, it only increases, not only does it increase the likelihood of terrible decisions, but it also increases the likelihood of high levels of fear, anxiety, and I think, so I think that it's really important. But the second element is, and this is also relevant in the context of another question that was raised with, I think, with respect to family planning, which is, you have to think about ongoing attendant requirements and needs that, in fact, don't go away in the context of the pandemic, but actually, are accentuated in many ways. And I think mental health would be one of them. I did note that the UNFPA has done a special appeal, I believe, at the end of March for about, I think it was about $67 million. Don't quote me on that. So I think it underscores the importance of resources, as I mentioned, not avoiding or not forgetting about attendant needs, and the fact that those needs not only remain critical, but have additional resource requirements attached to them in the context of this kind of a crisis.
Thank you. Marty or Paul, any other comments on mental health?
Well, just to maybe restate the obvious, it's the problem we haven't solved in peacetime. It's not going to get any easier in crisis mode. And, I think it's a pervasive issue that's being exaggerated. My only hope is that as all of the world experiences the challenges, the stress, the anxiety, the precipitation, that will increase our level of awareness and compassion for something that's probably experienced disproportionately by these populations on a more regular basis. So hopefully we will not only be more aware and more compassionate, but we will also recognize the need to invest in these types of parallel solutions. And if there's a silver lining, if we do that, it bodes well for all of us in the future.
Marty, I know I've heard you say in the past, and I've appreciated it so much, the importance of trust and the importance of clear messaging. And I think about that a lot in the context of refugee camps and urban refugees. Here's a very interesting question. I like it a lot about how do we get more information out to the field. So it says that the sharing of field experience is so critical. It's fantastic to see this effort to collect information. What else can we do to push this information out to those in the field who are so busy and overwhelmed and need more active feedback of ideas? So I know, Paul, that's been a major focus of your work. And actually, Eric, on your side, I think about the importance of Refugees International and your new report and helping people have this armamentarium about recommendations on health policy, but also for the field worker in camps, this, what do I do? This sense that the tsunami is coming, and how do we get that information out to the field?
I want to reflect, I want to answer respond, but I want to reflect a little bit. So I want to ask any of the co-panelists if they want to start.
Paul, any thoughts?
Yeah, I would say what's clear, and we've all a lot of us spent time in the field, is you're too busy to actually often think and write down. That's for sure. Our field would be so much better off if we had people in the field that had the time to sit down and record what they did, and we would have, or we'd be much more evidence-based. So, and that's not a criticism of them, they just have too much to do. So what we have been doing, and we would love others to be able to do too, is if you know people in the field who are doing interesting things, try to speak with them, and even just look at the form that we have. You can just download it and fill it out and then upload it, because the more we get, the more we will learn from that. And so the 3 universities have actually are working with a bunch of students. And so we've just begun interviewing people. And I want to just give a quick example of that today. So the person that we interviewed talked about what they were doing, but something came out that it was very interesting to me, twofold. Number one is that when you're dealing with refugees or IDPs, it's a bit like the Ebola and then suddenly taking them and saying you have to go to the ETU. But if you suddenly have a fever and then you have to be separated to an isolation area with a government that you don't trust, you can imagine the problems that's going to cause, and that's already happening in some countries. The second issue is more on a clinical issue, but there are limited. I saw there was a question about tests. There are no tests in most of the refugee settings. It's all done by the governments, sometimes only at the national level, at the capital, sometimes maybe in the region. So you can't really rely on tests. You suddenly have a fever. What do you do when the flu season? I saw, the flu season is coming in Asia soon, and you're going to have flu. You have malaria. You've got your rapid diagnostic tests, but you could have two. So how do you actually triage these? And I don't know if there are sufficient protocols yet to do that. So I asked today, and then I'll stop, but I asked today, and they said, well, we test, and if we do have rapid diagnostic tests for malaria, and it's not flu season yet. So if it's malaria, then we'll treat for malaria, and we won't put them into this fever clinic. But there are a lot of big, difficult issues. And I think the more we learn from the field of what they're doing, the better that will be.
Maybe just to chime in before we go back to Eric, a couple of thoughts. One about how do we leverage the acquisition of data and surveillance to glean best practices and sharing, and even worse practices. We want to be sharing the mistakes as equally as we share the successes. And I guess one of the things that is remarkable to me is with the majority of the world's population in some way participating in a remote sort of working experience, in a lot of ways working off-site where the geography is not quite as critical. I wonder if we can create these networks of participatory surveillance, whether it's using the availability of cell phones or other things, to have some of that data anonymized and reported, to have some experiences that are really useful in terms of narrative as opposed to quantitative, but just narrative experiences to highlight outliers or unique things and raise them to awareness. That can be done in a lot of ways through social media. And there's an enormous number of people who are both out of work and not doing their normal work, whether it's returned Peace Corps volunteers or all sorts of others, that perhaps could be brought in as curators of the participatory surveillance in order to assemble information and digest it, and others that might be able to visualize it or feed it into projections and models. So there may be an opportunity in this crisis to think about other ways, because Paul's point, and certainly my experience as well, on the ground in the field in the middle of battle, it's very hard to take all of those roles into a single person. And then the last comment that you made about trust, I think, is really important. There is a big debate going on right now globally as you compare countries' experiences on where people should be isolated or quarantined, and whether that's within a family unit or in a familiar, culturally comfortable community cluster, or whether it's through removal. And there's arguments, this is not a settled issue. There may be a technical solution that isn't accomplished with a trust-based solution. And as you've heard me say, Pat, the best technical advice in the world may be necessary, but wholly insufficient in the absence of trust and cultural acceptability. And so, but we could start to compare, we could use the variety of what's going on out there as a way to do these sort of case control observations of what's working and what's not working, what are the criteria of acceptability, what's the dialogue at the community level like. So this could help. I say that not underestimating the challenge, but I also think this virus is going to be with us for a long time. I don't think this is a one wave and over thing. And so there's a lot of value in having systematic pauses, reflections, and iterations on our approach, because we're going to get many hits, many whacks at this virus, in my opinion, over the next several months to maybe a year or more.
Thank you. Eric?
I don't have a whole lot to add, but what I will add is that when I first looked at this question, I sort of saw it as how do we get information to the field? And it was interesting to me because, my reaction was normally it's the other way around. And I think the conversation really revealed the fact that it's really a very complex it can be a really complex and valuable series of exchanges back and forth, right? Especially with respect to, some of the public health best practices issues to which we are alluding. But for us, an organization that uses field reporting to sound the alarm for policymakers, this crisis creates a very interesting challenge because we're not doing field reporting now. But what we are discovering is that phones and videos work, and they work throughout the world. And so we're testing some new methods as well. And and again on this question of the exchange, the back and forth. One example of that was very interesting to me was when we issued our report. We got feedback from one very consequential non-governmental organization expressing their appreciation of the report, saying that they felt it was going to be critically important in terms of their ability to get funding to support the response. So I think, I guess my overall observation is that it's not from the Bloomberg school, if you will, to the field. It's not from the field to the Bloomberg school. It's probably a pretty complex back and forth that creates, I think, very valuable opportunities.
Yeah, thank you. I think about work that I was doing in Thailand many years ago, where we had a very robust group talking about what was going on in a formal way. It was called the Committee for Services for Displaced Persons in Thailand, CCSDPT. And that group met every month. It was very hard to get in from the field, but it was probably one of the most valuable things that occurred for all of us, was to listen to all of our colleagues on the ground in various sectors, NGOs, IOs, the host government in Thailand, and creating something like that for major refugee settings was one of the most useful things that I dealt with as a medical director at a camp. A couple of other questions here, a little bit off topic, but it is about IDPs. Has India addressed the transportation issues to get migrant workers back to the villages? I know we've all seen that on the news, and it's a really sobering thing to think about, the number of remittances that are not happening from migrant workers to their family members worldwide, and then certainly migrant workers who've had to head home. And I don't know if any of you want to tackle that issue, but it's been a gigantic issue in India and elsewhere. Any thoughts or comments on that hard issue?
Well, I'll just say it's not limited to India for sure. We're experiencing something similar in the US with the migrant workforce, which is critical. And in fact, there's been carve-outs to a lot of the restrictions on entry into the country, specifically for migrant workforce visa holders, in order to be able to facilitate that continuance, both as a necessary aspect of the engines of the US economy, but also from the perspective of remittances and other aspects. And clearly, the other thing we're seeing in a big way, the transportation between a home environment or some other environment and the workplace in terms of migrant issues, and the challenges of that for mixing and spread and amplification, but also the challenge of transportation in what I am witnessing as the world's largest global repatriation, I think, that we've ever witnessed. A long time back in the planning for an influenza pandemic, there was a big discussion about whether the policies were going to be shelter in place or repatriation of nationals. And I think, regardless of what a lot of people thought in theory, as this evolved, the emerging principle globally has been around repatriations. And considering the proportion of the world that is living outside its country of birth for more than a year, in terms of that definition of migrant, it is stunning to see what is happening from a perspective of global repatriation. And how do you do global repatriation in a safe way, in a way recognizing the asymmetry of the pandemic around the globe? How do you do it with the Achilles heel of asymptomatic infections that unknowingly get spread through repatriations that are well-intended, not necessarily forced, but voluntary and mutually agreed upon repatriations, and the risks and the vulnerabilities of inadvertently seeding one country from another? It's really an enormous issue. And I'm sure there will be many sort of historical reflections and PhD theses written about what happened at this time with this global, repatriation of people.
So speaking of history, any of the three of you like to tackle the question of, what have we learned from history in specifically as it relates to refugees and IDPs, and lessons learned from refugee camps or elsewhere that might help us, generally speaking?
I want to start. I can't really speak to the specific historical references around displaced populations, but I will say, having spent a couple of years, 2005 to 2007, together with Dr. Howard Markell at the University of Michigan, looking at the 1918 influenza pandemic and what we learned historically from that time. And this was a study published in JAMA in 2007 in August. We looked at 6 months of the fall wave of that pandemic every day through the lens of 3 different daily newspapers that could report on both the daily death counts as well as the social distancing measures that were put in place in society, school closures, mass gatherings, a lot of what we're seeing right now. And we overlaid the 2 of those. In fact, that study was a precursor to this flatten the curve, strategy of we watched cities that were late and didn't do much of anything, historical massive peaks, unmitigated, like Philadelphia, in comparison with St. Louis, where the curve was flattened. When measures got released, there was a rebound depending on when they were released. And 43 different cities were laid out in that work. And what I have seen is people said the results were irrelevant because they were 100 years old, and we now move at much greater volume and speed, and the world's more populated. But it is stunning to me to see that concept of flatten the curve and social distancing implemented, and its corresponding success. So despite the fact that we're facing this really horrendous virus with no medical countermeasures, the social distancing works, and it is reassuring in some way that something works. The question is, how can we adapt those principles, and how much of it is enough? Because it tends to have to be layered in multiple phases. It works better if it's applied earlier before you really know you need it. And it has to be sustained longer than most people are comfortable. And so that's where you get the greatest benefit out of that. But it really makes a difference in terms of not only the peak, the speed of the acceleration, but also the surge on health, preserving the surge on resources and buying time to come back with a treatment or a vaccine. Can we learn those historical lessons? And can we learn from the real-time history that we're living through in order to figure out solutions for refugees or IDPs or other types of migrants? That's the challenge that I think we're facing.
Eric, from a policy perspective, any thoughts or lessons?
Yeah, I mean, I would put it a little differently. I don't disagree with the word that Marty said at all. But I think that that this crisis reveals to me that that profound political and governance challenges do not have technical solutions. And I'll take the opportunity to look at one of the questions. You had 2 sets of questions. You had, I guess, the chat and the Q's and A's. So someone asked a question about the CDC order, and talked about the fact that there's language in there in the order about permitting DHS officers to take humanitarian considerations into account. May I use profanity on this in this environment?
You're being
Because we know
recorded.
I beg your pardon?
You're being recorded.
Well, we know that's bullshit. This CDC order is a political order. It's not an order grounded in public health considerations. And that language about humanitarian considerations is either anticipating litigation risk or public relations. But this is about politics. And so the real question when you're dealing with how to avoid the targeting of and the sacrifice of forcibly displaced people, whether they're at the US border with Mexico or whether they're fleeing Iran, 200,000 by the last count I saw, into Afghanistan. The real question is, how do we get to a place where we don't, in the first instance, demonize the other? Because bad policy decisions that are not evidence-based, if they're not evidence-based, then they're based on something else. And so the real question, that we're struggling with is, how do you issue a report as we issued today about, you don't have to expel asylum seekers, when we know that probably if a majority of the populations of the United States and around the world were polled on the issue, they would talk about, they would support perhaps the expulsion of asylum seekers. And so how do you get at that issue? That's a problem of governance and politics. It's not a problem of science. And I think the answer has to be education. There's no other alternative. About pointing up the discriminatory aspects of certain policies, emphasizing the contributions that the service providers who are serving us now in circumstance, the essential workers, such a high percentage come from immigrant communities. I mean, it's got to be in the world of governance and politics. We can't give up, but we can't assume that that these political problems are going to have technical solutions. They're just not. And to me, that's the biggest challenge that we really have to. And I don't know if it's a challenge for the scientific community. Maybe it is. Maybe it's not. But I think it's a challenge for all of us.
Thank you, Eric. Paul, did you?
Yeah, a couple quick things. I saw in one comment, and I agree. I mean, I'm thinking of some of the mistakes that we make continuously. One of them is that we concentrate too much on camps and not out of camp, and that was that last comment, and I would agree with that. One of the reasons we do that is that camps are so dependent on the international community, where people outside of camps are definitely dependent on the international community, but generally they also have other ways to be able to, but it's not a good excuse, and so I agree with that. Getting back to the other thing that I think that we see repeatedly, and I agree with Marty that I've never experienced anything like this. I guess none of us haven't, unless we were living in 1918. And so what doesn't surprise me but makes me sad is that when push comes to shove, government's going to take care of the nationals, and so refugees and many cases IDPs are going to be out on their own. And yet we don't have the leadership right now, and the community. We don't have the leadership that is saying, let's all get together and start trying to address this. And I'm talking about both in the U.S. but elsewhere. So these people are really, if the virus does go into some of these refugee communities, whether they're urban or not, they are not going to have the same access to the nationals. And I'm pretty sure in some places, and I won't name countries, this may be an excuse for massive refoulement in some areas. And then the other thing that I guess we could see, we'll clearly see an increase in stigma and discrimination, a lesson learned we see over and over. But then Finally, and I think this is a technical issue, is I am positive we're going to see a significant increase of deaths, possibly even more of non-COVID, as we've talked about. But the problem here is it's extremely hard to prioritize, to say we're going to do this. So yes, we need to continue with family planning and treating, dealing with sexual gender-based violence, but everyone gets so focused on the epidemic. And particularly when we don't have a test right now in many of these settings, I'm really concerned that we have to continue to do that, to focus on COVID responses and preparedness, but we can't let everything else go. And we've seen this consistently.
Thank you, Paul. Well, I think we'll wrap up at this point. I would say that it's been a real pleasure having the three of you on today. And if I have any hope, it's that we continue these conversations, the clinical, the research, the public health, the policy, and we all raise our voices to try to help refugees and IDPs. And thank you to all the participants for your information. We had 175 participants at one point on the webinar. So keep your eyes out for the ISTM webinar, May 6th, and we'll continue doing this kind of work together. Thank you all very much.